Ready? Welcome back everybody after lunch. Hope you've all enjoyed your lunch and ready for the afternoon session. So my name is Anne Robinson. I'm the Divisional Operations Director for Medical and Critical Care at Goulburn Valley Health, and I will be co-presenting with my colleague Penny Whelan, who is our Nurse Unit Manager of our Emergency Department. So we've been requested by GV Health to come down to talk to you. With the whole of organisation did a plan for our winter strategy. Penny and myself's area of main responsibility is our emergency department, so we will be focusing our presentation around our emergency department. The organisation did develop an organisational plan to embed good practices that will improve timely access and flow across all streams for better patient outcomes and improve staff satisfaction. That is a whole of hospital plan. It's not just an emergency plan. So it's a process that we're embedding across the whole of the organisation. Within that plan, there were several steps that were developed. Most of those that we're going to discuss today were around the emergency department, which I'll go into in more detail in a minute. But one of the ones certainly was around the flu vax program across the organisation. GV Health we did a lot of work on our flu vax program, and certainly the media campaign that came from the Department of Health and Human Services this year certainly saw a marked improvement in participation by both the staff and members of the public in our area this year, and we improved our rate of vaccinations by 3% this year, so achieved the department's target of we actually got 80.2%. So we achieved the target. Interestingly, when we started the flu vax campaign, we have just over 3,000 staff in total at GV Health, and within the first 3 to 4 weeks of the campaign we'd actually immunised 20% of the staff. So and I think that that's attributary to the media campaign that actually was run, that everybody was really on board with what was happening. We had people asking for the flu vax before it actually was released, so well done to the Department of Health. So the next slide really is just looking at what the average daily presentations have been to our emergency department. Obviously Goulburn Valley Health is a regional hospital, so we don't have the numbers that the metros get, but we have seen quite a substantial increase on 4 out of 5 months of our average daily presentations to our emergency departments, and a lot of those have been influenza type cases as well. The triage categories, so again, the acuity of the patients that are now presenting to our emergency department, our acuity, so our number of patients arriving is increasing, and our acuity is also increasing, which is obviously placing a challenge on the department itself. Presentations by day of the week. We used to think that Wednesdays was our quietest day at Goulburn Valley Health. It's now getting up there with the rest of them, and Thursday now looks to be the quieter day at the hospital. So if there is ever such a thing as a quieter day at a hospital, which I don't think there is. So when we actually looked at the days of presentations for our emergency department, part of our winter strategy, but also part of our strategy from an organisation as a whole, was to look at our staffing levels in our emergency department and how we actually target staffing to the specific requirements of the department. So we have implemented a rapid access and triage process, which has been in place for nearly a year now, with a senior nurse and senior medical staff working out the triage to try and assess patients in a more timely manner. We have had funding provided from the department for an ambulance offload nurse, which we're actually still working on the implementation of that, but we hope to have that up and running very soon. And certainly we looked at the medical staff in rosters and we have amended the rosters so that we actually have more medical staff starting work later in the day, so that it's actually there for the for when the bigger amount of patients present later in the day. One very pleasing thing for us to see as a hospital is our discharge destinations, that we actually, our discharge homes, that's probably not one we should be happy about, has decreased slightly. What we're pleased about is that our transfers out to other hospitals, so to the metros, has actually decreased, and our admission to the wards and our admissions to our short stay units have increased, which means that our capacity to actually care for patients within our region has actually increased, which is fantastic. Also, our discharge to other destinations has decreased, and that also includes in that cohort patients who have actually been discharged after receiving initial advice at triage. So they're not actually leaving because they've been left without seeing, they're actually leaving after they've received some initial advice. So that's fantastic news for us. So with our activity objectives, one of the things that we have received lately is additional funding for our intensive care and medical unit beds. I don't know who's aware, if everybody's aware or not, so Goulburn Valley Health is at the minute in the initial throes of a redevelopment. And so about 18 months ago, we actually looked at the organisation, looked at where we could possibly find more beds that we could possibly open, which was a challenge. But anyways, we actually opened an additional 5 medical beds, and we're in the process of trying to open an additional 2 intensive care unit beds. Those are both certainly in the process of opening and are very much being used in great demand. The other thing, and one of our most successful strategies, is the development of our RAPU model of care. So again, that's in the early stages of development. It's been running now for about 4 or 5 months. As other hospitals have already explained about, part of our RAPU model of care is also to have a rapid assessment clinic. So not only is that able to assist with patients from our that get admitted into our RAPU model of care, but also patients who are seen in our emergency department who may sit on the border of whether they need to be admitted or whether they could safely go home. With some supports in place, we can actually bring them back to a clinic the day after and have them assessed again, so we know that they're safe. GPs can refer directly into the rapid assessment planning unit clinics, so patients who GPs have previously been referring into our emergency department can actually refer into this clinic. So it actually is reducing some of the demand on our Cat 4s and 5 presentations, which is fantastic. I'm now actually going to hand over to my colleague Penny, who's going to talk you through the ED specific parts of our presentation. Thank you.
Thanks, Sam. Thanks, everybody. I do apologise if anything occurs with the amount of patients going into the EDs, because the Q word was mentioned, but we won't mention that word anymore. So with the work that's been done with RAPU and all the work that has been done, we've actually increased our NEAT by 4%, which is just a slow progress, but we will continue to work on that. So the main focus on ED was actually to work with the staff, is to make sure that they're actually happier at work and things like that. So just working out what their barriers were. So we've worked on the senior leadership group, so they're trying to get them to work more collaboratively together instead of being in a silo situation. So we started to have rounds at the start of each shift for handing the information over, and then working with the ANUM and the admitting officer to work closer together throughout the shift to know where we're at with everything so that we can escalate as soon as possible. Also with the nursing staff is that we've actually started to do some pod nursing, which is to make them work closer as a team. They were working as a team, but they could have worked a bit closer. So the next step will be then to try and work with the medical staff to try and align them into an area with the nursing staff, so it's a team approach. But the team isn't just the nursing and the doctors, it is the clerical, it is the hotel services staff, so it's working with them to make sure that they're involved, they know what's going on and everything. We've been able to increase on our FTE, which has been fantastic, and that has actually helped a lot of the staff. There's not as many extra shifts being done, decreased sick leave slightly with this, so that's been fantastic with the staff, so they feel more comfortable and things like that. So we do postgrad studies for the emergency department, and we are progressively increasing the staffing levels going into those courses over the next few years, especially in preparation for the redevelopment. So we do struggle with recruitment, as everybody else does, especially from a nurse practitioner point of view. We struggle to recruit there, and any specialty areas within the organisation, that's medical and nursing side of things. So it's just trying to work on our recruitment process. The HR department is working on the process of trying to fast track some of those recruitment processes, which is fantastic. So the team in the ED, it's just focusing on them, making sure that they're aware that they're needed and we care about them. So that's our biggest focus. For 2019, we are focusing on, we're going to be shortly starting the daily operating system for the organisation, improving the flu vax, as Anne said. Hopefully we can improve even further than what we did this year, and continue working on the RAPU model. But the main thing with the staff is just knowing that they're there, and when all else fails, it's bring the chocolates out. And that helps. So that's it. Yep, thank you. Any questions?
I've got a question,
Yeah.
which you might want to repeat. I'm not sure. No, you can hear. Okay, great. Just with your kind of, I guess that was in the ED, but in terms of, did you do anything to kind of to work with your inpatient colleagues, I guess? So just sort of looking just outside the ED. Did you do any work this year with them? I know that you had a kind of an improvement project that you were working on, and how did you involve your inpatient colleagues in that?
It was about especially highlighting the patients that have potential influenza, making sure that we're aware, and it's just trying to highlight the patients and try and highlight earlier patients that are going to be for admission and things like that. There is still a lot of work to be done, and we want to work with them to also improve the handover process as well. Just as with the Northern, our testing for influenza is 5 to 7 days before we get results. So with very limited single rooms, there has to be a lot of communication regarding that. So there's a lot of communication in the bed meeting about what's required, what patients are there, and strategically thinking about what can we do if we are getting at capacity, what are we going to do? We're at capacity a lot of the time, but what else, thinking outside the box, what can we do? Can we move patients to the paediatric ward and things like that?
I guess with your staff challenges, that was, I guess, one of my other questions, because it's a common issue in rural settings, and I think our Metro colleagues think they've got staffing problems, but you know, it's nothing compared to some of the, I guess, the regional challenges that are faced.
Yeah.
You know, does that enable you to think out of the box in terms of the types of models that you put in place, or does it enable you to kind of look outside the hospital to some of the other, you know, community health and kind of primary care sectors to sort of think about, well, what can we do with those other sectors, I guess?
Yeah, definitely.
I'm interested in that.
Yeah, so we involve our HIT program quite a lot in planning for the day. So, and we have in reach for our nursing home patients. We do have some constraints there with the GP support. So we're actually in the process of reviewing that. What else can we do for that to keep the nursing home patients in their home and things like that? So there is a lot of work to do, but the community group within the organisation is very well utilised and are always putting their hands up for any patients. Yeah.
Can I say something? Am I all right to still speak? Yeah. So the other thing, sorry, from an organisational perspective, the other thing that we're doing, we have a collaborative working with the smaller rurals and with the GPs. So the smaller rural hospitals around us, we work very collaboratively with them. We're at the minute we're trialling a telehealth from our AD to one of the smaller rurals to try and reduce the amount of times that they need to send patients to us, that we telehealth with them as an alternative method. Obviously there's only certain patients who would come to our AD from that area that we can telehealth with. If they're a category 1 or 2, then they still need to come to us. But we're trialling that with one of the organisations. If we can make that work and it's seamless and it's working, then we'll actually look at rolling that out across other smaller rurals. We now have access to what the bed capacity is for the smaller rurals as well, so that when we're at capacity or when we get into capacity, or before we even started to do that, at least we have a full view of what everybody's capacity in the region is like, so that we're because, you know, in fairness to the patients, they all want to be nearer to their own homes. So if they're from a smaller rural hospital and they've got a bed available and the patient's stable enough to go back, then we actually let them go back. And I certainly think telehealth is one of the ways of the future for rural and regional hospitals to facilitate patients being back in their own areas but still receiving the care that they should be provided with.
And is that online, and can everybody see that in the region? What's the information about bed availability?
It's so with GV Health as the regional for in our area, so we can see it for all the smaller rurals and they can see what we've got. So as I say, there's 4 or 5 hospitals involved in this at the minute. You know, we'll see how it goes, and then
so is that in real time?
Yes.
Is that
Yep.
updated
Yes.
in real time? Oh,
Yep.
that's fantastic.
Yep. So so there's lots of small projects there. We probably just need to bed them all down into bigger, more productive projects.
We have a question from Andre Patrice, who's in our subacute area here, the department. Who do you staff your RAPU with, especially in regards to medical staff?
So we have 2 RAPU physicians who do a 7-day on, 7-day off roster. And so they work 10-hour shifts every day. So 8 till 6, 7:30 to 5:30, around that time. We have medical registrar support for them while they're there, and an intern support. The RAPU is currently run as part of our acute medical ward, which is a 45-bed ward, and 20 of those beds are currently used for RAPU, but they can certainly be interchangeable depending on whether the demand's for acute inpatient or RAPU. We have dedicated nursing staff-wise, it's dedicated nursing staff to those areas as well. So it's a 7-day coverage. It is only 8 till 6, but we do a medical handover meeting at 8 o'clock every morning with the medical registrar who's been on call overnight, and the RAPU physician goes to that bed meeting, and if patients have been admitted overnight that meet the criteria for RAPU, then they're pulled out of acute inpatient and transferred into the RAPU model of care. In the RAPU model of care, we have got priority access for radiology, pathology, pharmacy, allied health, so that certainly assists in our turnover, and we've decreased our length of stay quite substantially already for our RAPU.
Can I ask about the ambulance offload nurse?
Yeah.
How does that position work?
So
How often is it there?
So we're still working through the model and still in the recruiting phase as well. But the way will be more of a transition position. So within the department, because there is we've already filled every cupboard in the department. So it's making a space that we can have a couple of trolleys. So transitioning the patients that are waiting to go to the ward that are suitable, they could go into this area and we can offload the ambulances straight into the cubicle and start working them up. So it'll be during the afternoon shift, so that nurse can be assisting the work-up phase of those patients if the nurse that will primarily be looking after them is already on the ward or at CT or something.